Not that I want to be. So thank you very much for joining us for this month's Research Echo. I have the pleasure of introducing our speakers. And so starting out with our didactic portion of the program today is Dr. Erica Ziller. And Dr. Ziller is the director of the UVM Larner College of Medicine Health Services Research Center, and she joined UVM here in fall of 2023. She also directs the newly funded Northeast Rural Health Research Center, which is one of 8 national centers funded by the Federal Office of Rural Health Policy. Dr. Ziller earned a master's degree in health policy and management and a PhD in public policy at the University of Southern Maine. And her career actually started at University of Southern Maine in 1998 as a research analyst, and progressed to a faculty position where Dr. Ziller served as the director of Maine Rural Health Research Center and chair of the public health at Southern Maine University. Rural and public health, as well as health policy, have always been at the heart of what Dr. Ziller's work has been. And throughout her career, she's received federal funding from the Federal Office of Rural Health Policy to conduct research on rural health issues, particularly using secondary data. And so today, Dr. Ziller is going to be leading the didactic portion of the Research Echo, talking about publicly available databases. And so without further ado, Erica, I will turn this over to you. Thank you.
Thank you, Kim, for that kind introduction and for the opportunity to be here and to talk about one of the things that excites me the most, which is data. Ever since I think the first time I read a data dictionary from a publicly available survey, my life changed, and I have pretty much built my entire career on figuring out really interesting research questions that you can answer with publicly available data and securing funding to do so. So super excited to have the opportunity to share some of that enthusiasm with everybody. Is everyone seeing the presentation slides? Okay,
Yes.
perfectly. Perfect. So my agenda and plans for today is to provide some concrete examples of data that are available for clinical and or population health research. And in particular, I'm focused on data that are free, easy to download, and that you can answer some very interesting and varied questions with. I tried to pick an assortment of different data sources to talk about. And I'll be sharing information on 6 different data sets and providing information both about where they come from, what the data look like, what the contents are, and also provide some examples of research cases and ways that these data have been used and published on for health services and health outcomes research. And I'll wrap up with just some overarching recommendations for working with publicly available survey and other types of data. So to start, in preparing for this, I did some research to try and figure out just how many federal and or state health data sets exist out there. And the estimates that I found ranged from somewhere between 700 data sets that could be used for health-related research to upward of 2,000. So there is no shortage of data opportunity for people who are interested in working with secondary data out there. The sources of data range from things like public health surveillance data, so birth certificates, death certificates, et cetera, that could be downloaded from CDC Wonder, to very large scale national surveys. And some of the data sources are restricted, some have costs, some very substantial costs. For example, Medicaid or Medicare claims data can be really, really costly to use. but many are available for free or low cost and able to be readily downloaded with very little difficulty. And so I'm going to focus on 6 of those. That's just 6 out of the 700 to thousands of different data that are available. The first source that I'd like to talk about is the National Health Interview Survey, which is collected by the National Center for Health Statistics within the federal CDC. This is a data set that I've used quite a bit over time, and historically, they have not had a rural-urban indicator in their public use data, which led to a whole bunch of challenges, including having to access the data remotely and applying for all sorts of special secret status. But they've come a long way in recent years, and starting in 2019 have made at least a small rural indicator available in the public use files. So the National Health Interview Survey, we often refer to it as the HIS or the NHIS, has been probably the longest running survey related to health in the United States. It's been collected since the 1950s and obviously changed extensively over time. But the core questions really are focused on healthcare access, healthcare service use, and a number of different clinical conditions. And when I get into some of the examples, I can share some of the research that you're able to do with these data sets. Every year they go out into the field and they collect information on somewhere around 27,000 adults and 9,000 children. One of the great things about the HIS is that it has a really strong collection of sociodemographic and economic characteristics. So it has information about race, ethnicity, about education, income, particularly income as a percentage of the federal poverty level. In recent years, they've started collecting information on sexual orientation and other health-related social needs, which is really helpful if you want to be able to get a nuanced picture of the risk factors associated with different health conditions and health outcomes. And in particular, this data set is really, really good for tracking healthcare access. So I'm currently using the HIS with a couple of different research teams here at UVM and with my colleagues at the University of Southern Maine. We're doing some work right now on rural-urban differences in chronic pain and in high-impact chronic pain. Some of the best data that we have about chronic pain as a national chronic condition of concern comes from the National Health Interview Survey. And in the past, the CDC itself has conducted a few crosstabs that indicated rural people might be disadvantaged when it comes to chronic pain. We've been able to really delve into that, to do some epidemiological analyses and learn that basically, no matter what you control for in your models that is available in the HIS, we still see that rural residents have higher rates of chronic pain, and they are managing their chronic pain in different ways clinically. So much more likely to be using opioids or other prescription medications for pain, less likely to have access to multimodal or alternative forms of treatment for pain. So this is just one minor example of a way that you could use this data resource. I'm working with members of the UVM Cancer Center to look at recent cancer survivors and just their general health and well-being across a variety of different outcomes. So a couple different examples of these data. what they can be used for. Another data set that I get very excited about is the Medical Expenditure Panel Survey conducted by the Agency for Healthcare Research and Quality. This survey has been around since 1996. Again, it is collected every year, and it has some of the richest, most detailed information on healthcare use and healthcare costs and conditions that are available at all in the United States. And they are available free of charge, easily to download right off AHRQ's website. The sample is about 22,000 people a year. They cover both adults and children, which is great. And the survey itself has multiple components and data sets. So if you're interested in something pretty superficial or easy to look at, rural urban differences in rates of health insurance over time or something like that, you can work with the household level file, which is consolidated. It has all the different components are kind of summarized into costs. If you really want to get granular and get into different chronic diseases or other health conditions and look, for example, at a study that I conducted a few years ago was looking at people with mental health diagnoses and delving into the prescribed medication files, visit files, and comparing whether or not rural people were more likely to be receiving medications alone, medications in tandem with some sort of psychotherapy, which is evidence-based best practice for mental health treatment, or just receiving psychotherapy, and found, not surprisingly, rural people were receiving lots of meds and much lower rates of actual therapeutic visits with a counselor of some sort. So, so many different diagnoses and hospitalizations, ED visits can be studied in the different visit files, and different prescription drug medications. Really, really rich source of information on both, conditions and healthcare use, but also costs, including breakdown by, who's paying those costs, whether it is payers themselves or patients paying out of pocket, and how that's changed over time. So I did a quick PubMed search and found in the last few months, people have published on costs for patients with all sorts of different conditions. There was a recent publication on the costs, out-of-pocket costs for lower extremity fractures. They've done some analyses of different GI cancers, et cetera. And then again, the study that I mentioned on mental health treatment. So moving on to the third data set that I get very excited working with is the National Survey of Drug Use and Health, which is collected by the Substance Abuse and Mental Health Services Agency, SAMHSA. This survey has been around since 1990-ish, and it has a sample of somewhere between 60 and 70,000 people each year, and they cover kids from age 12 up through as old as we get, although for most of these surveys, actual age is capped usually around age 85. But people older are included, their ages are just in the data capped at 85. The interesting thing about this particular data set is that they actually interview the youth themselves. So you're getting actual information from kids. Some of these other surveys, for example, the HIS, its parents providing information on behalf of their children. So, so this is kind of interesting and unique. The content is very heavily focused on mental health and substance use concerns, and that includes alcohol, tobacco, and illicit substances. There are a lot of questions both about prevalence, but also access to treatment, even things like workplace policies related to substance use. The NHDUS, NSDUH has lots of demographic data, and like the HIS and others has begun including information such as sexual orientation and providing a rural-urban indicator for research, which is really helpful if you're interested in working with underserved populations. All of these surveys that I'm talking about have, basic income information, basic race and ethnicity information, basic sex and gender information. So you can always do analyses for those populations, but the ability to look at sexual orientation or rural urban are things that I've called out as particularly important when they're available. So again, I've used this survey a number of different times. I am working with Dr. Valerie Harder on some proposal ideas. I've also been working most recently with our main team, looking at rural-urban differences in access to substance use treatment for people who have substance use disorders, including alcohol dependence or other illicit substance use. So we're doing that right now. A quick PubMed search found that these data have been used for a whole huge gamut of different types of studies. Most recently, there have been some studies on suicidality among US veterans, and a team and I published in the American Journal of Public Health a few years ago, looking at rural-urban differences in trends of adolescent tobacco use. So you can do trend analyses, you can look at special populations, and you can look at a whole host of health outcomes and access measures as they relate to mental health and substance use. The National Ambulatory Medical Care Survey is another great source of data. Unlike the others that I've mentioned, instead of being person-level data, these are actually visit-level data. And the annual sample contains about 17,000 patient visits to different office-based healthcare providers. And it includes a whole bunch of different sociodemographic data for patients, basic information about the providers, for example, specialty, practice location, etc. And you can use these data to study a whole variety of different things that are happening in primary or specialty care in an outpatient ambulatory setting, in an office-based setting. And so some studies that have been published recently include an examination of trends in diabetes medication prescribing over time in different settings, including region and practice type. We have used these data to look at tobacco screening and treatment referrals and treatment offerings in rural versus urban primary care practices. And part of what we looked at was the role of electronic medical records in helping to facilitate both the screening and treatment of tobacco use. And we're able to publish that in the Journal of Rural Health. So it's a great resource for digging into what is happening nationally in different office-based scenarios. Probably most everybody is familiar with the behavioral risk factor surveillance system. The HIS may be the longest running, but the BRFSS is the largest survey we have of the health of US populations. It's a state federal partnership in that states are really responsible for collecting the data, and then it feeds up to the federal level, gets harmonized and made available as a national data set. There are about 400,000 adults with extensive amounts of information about population health risk factors, ranging from diet and exercise to environmental health factors such as, radon and radon testing and exposure to Lyme and use of sunscreen, just all sorts of different risk factor information. The sociodemographic data that are available are somewhat dependent on states. A lot of states have, in recent years, really worked to be able to identify transgender populations, and certainly, in addition to gender minorities, sexual minorities as well, so lesbian, gay, and bisexual populations. Other states have not included those modules, and may not have that information available. There is a rural-urban indicator in the public use set, which is great. And I popped into JAMA just to see who'd been publishing recently with the BRFSS, and just in the last month or so, there have been some studies on mammography changes following recent guideline changes. There's been some analyses of social isolation and who's at risk of that. Some examinations of lung cancer screening in response to guideline changes. And I myself have used this in collaboration with colleagues to look at rural-urban differences in adverse childhood experiences and associated mental distress in rural populations. And then finally, the last data set that I wanted to provide some information about is the healthcare utilization. Few different data sets collected by the Agency for Healthcare Research and Quality. And these, unlike the others that I mentioned, are not completely free and not completely downloadable by yourself from the internet. You do have to sign a DUA. You need to buy the data. They're about $1,000 for a year's worth of data. And at the same time, they are such an interesting and unique data resource that I thought they were worth mentioning. They're huge, and so they won't send them to you unless you acknowledge that you're going to be able to deal with these many gigabytes of data that they send to you. They have about 30 million ED visits per year and 7 million hospitalizations. It makes them challenging to work with, but really wonderful for researching any possible condition, diagnoses, procedure under the sun that you might be interested in that happens in an ED or a hospital. The demographic data is pretty limited. And on the upside for rural urban, there's an indicator in the public use data, both whether the patient was rural or urban in their residence and whether the facility that they went to was rural or urban, which has allowed for some nice comparing and contrasting depending on the types of questions that you're interested in. And so recent studies that have been conducted with these data and are showing up in PubMed include appendicitis imaging trends in the ED, looking at adolescent self-harm diagnoses that are presenting in emergency departments and sort of the disposition of patients after those those visits, fatal and non-fatal firearm injuries, traumatic brain injuries in the ED. And I and my research teams have used these data for studies of rural opioid poisoning trends and changes over time in rural EDs, and also are doing some work with it on trauma outcomes for people that are living in ambulance deserts. And so that's the list of the data sets that I have to share with you. I can answer questions about other types of data that might be available, but wanted to touch on a couple of strengths and challenges of working with public use data. The strengths are, first, that the data are super easy to get hold of. Most of the time you can just download them easily from the internet. The questions are well validated. You can study, as I hope I've illustrated, lots of different conditions and upstream factors related to health. Many of the data sets include information for underserved populations that are of research interest. Many of them have very large samples, or if their samples of populations of interest are not big enough, you can pool multiple years together to boost the sample size for smaller groups. Many of the data sets, because they've been collected for such a long time, are feasible for trend analyses. And these data are really great when you are trying to work with new collaborators on a topic area and you want to publish together because you're going to apply for some funding and you want to show a track record, or you have a student or trainee that is looking for a project and you can give them a data dictionary and say, here, come up with some ideas, and they can get their project done in a really quick period of time. So some great strengths to using these data. There are also some challenges, which are that the questions could change between years, and variables that you might really wish you could look at are not available. Oftentimes, rural is not available on many different data sets. Survey data are based on self-report and therefore subject to different sorts of biases. Most of these data sets exclude people who are living in any sort of institution, so like a nursing home or a correctional facility. Those people are excluded. And most of the surveys require very specialized analyses. I talk about some of the tricks of analyzing complex survey statistical analyses on this slide, but I think the most important thing is reach out to the Bird Corps or others if you're needing help, because complex survey data, you need to know how to analyze those. And finally, if you happen to be interested in collaborating on anything related to rural health, you have a question that you wonder if could be answered with public use data, reach out. I and my team are always looking for collaborators, and my contact information is here.
Wonderful. Thank you so much for that information, Erica. I put links to, as you were talking, I looked them all up and I put the links in the chat if anyone's interested in tracking any of those down. Questions or reactions? Has anyone worked with these data sets?
I see Ben nodding.
Yeah.
Yeah, I've used I think all of those data sets at various times. My favorite is NHANES because
Yep.
it's got blood test results on a gazillion patients and a huge number of different blood tests. So we've been able to look at, say, the association between serum magnesium and depression, or magnesium intake and depression. And that one is a particularly robust data set. Also use some state data sets that are often really wacky. We did get all the driver's licenses over dozens of years from 7 different states that made them available to us, and use that to look at self-reported weight and height distributions across rural and urban development areas and a bunch of other tricks with that data. So there's weird little corners of the data world to explore.
Erica, Jen Holmes asked in the chat if there's a web page with these types of resources that's readily available that we could share with. We get lots of requests from students and faculty around some of these things, and I just wonder if that's been developed.
I don't know if there are websites available that sort of have all of these basic ones with links to them, but I feel like that's something maybe the Health Services Research Center ought to develop because it is such a great resource. I mean, people can feel free to reach out to me. I think thanks to Carrie for putting the links to the ones I was mentioning in the chat. That's really helpful. I have a spreadsheet that has some of them listed with pros and cons and links to where you could download that I'm happy to share. It's probably about 20 different data sets. Including the NHANES, which is a great one. I haven't used it myself, mostly because you can't get a rural urban indicator out of it, but there've been, yeah, it's not in there.
And I feel like there's potentially, it's a bit of a moving target. We participate in numerous studies where we're contributing to databases. So there's, numerous amounts of them. And I think of things like the ABCD study, which is the adolescent brain cognitive development. They've made a commitment that once that study is completed, that those databases are going to be publicly available. So, I just think about some of the things that we're contributing to, and some of the bigger projects that we work on. Collaborating with researchers who are involved in that may also allow people to have access to data that's not publicly available, but readily available.
I think that's super helpful. I mean, you had mentioned 700 and upwards of 2,000. So, I mean, one thought would be, I wonder if this is worth a newsletter article that could be posted to the NNECTR, sort of capturing some of this information and listing, those top 10 or top 6.
Great idea.
Yeah. Peter, I see your hand is up.
Oh, yeah. So hopefully these data sets will continue to be collected and available. It's great. The data's out there. It's great to be using it to actually learn something. You were talking about public use data sets. Many of these also have restricted access data sets, which take a lot of steps to go through to get access. They have more information. Is that the issue?
Yes. So historically, the National Health Interview Survey before 2019, the only way to do rural urban analyses on the data was to go to a physical data center. So one of the census data centers, for a brief period of time, they had like online seats you could purchase to analyze the data. They had some weird program called Andre, which we described as our abusive boyfriend, Andre, because it was very, very difficult to work with and sometimes provided no output whatsoever. But yeah, if you have to use restricted data, life gets very, very tricky. Unlike the National Health Interview Survey, MEPS, the Medical Expenditure Panel Survey, used to have a rural urban indicator, and then in 2014 they decided it was an identification risk for subjects, and they got rid of it. And that was right when I was, working on my dissertation and hoping to use some of those data. So yeah, very, very challenging.
Yeah, well, speaking of data sets that are difficult to use, we'll move on to our case in a second. I'm going to have Kim introduce Jonathan. Benjamin, is your question quick or comment?
No, it was just a reminder that we've got the claims data from virtually all the healthcare delivered, at least in the state of Vermont. I think Maine has it also. And also quite difficult to access behind a double secure barrier door with a dog who bites at you if you get too close. But we were able to use it to do quite large studies. So
Yeah.
Awesome. Thank you for sharing that. I saw that was in the chat too. Is there a link to that or?
no, you have to go through someone's secret at UVM. It used to be Charlie McLean, but I don't know. Erica, are you doing it now?
You can talk to Caitlin Damon through IT, and she can tell you what you need to know to get access to the data.
Awesome. Thank you. Kim, would you like to